Okay, I'm still not the host.
Okay, I've pressed record, it's fine.
All right, okay, thanks.
Yeah,
thanks.
okay.
So I'll straight go into the presentation. Thank you so much for joining us in this presentation. My objective for this presentation were very simple. I wanted to look at this shoulder ultrasound MSK, which most of the time we are encountering, and we see people doing it, and we are having patients who presents with shoulder joint pain. And for some reasons, we may be having some challenges in attending to this shoulder ultrasound. Not only that, sometimes you tend to have a patient with shoulder pain where they do a plain X-ray, and X-ray doesn't review any pathologies or any abnormalities, but whereas ultrasound may help you to assess the soft tissue injury. So I'll try by all means to go through and guide you with the protocols of shoulder ultrasound, indications, the common indications, and then the technique that is also required to perform a shoulder ultrasound, then common shoulder pathologies that I gathered, and then the scanning pitfalls that are involved in shoulder ultrasound and generally in musculoskeletal ultrasound. Then I also give some samples of documentation on how to report. Half the time, sometimes we tend to see the pathologies and we don't know exactly what to comment on. So I'll try to stress on specific things that we are supposed to record on. So, can it move? Okay. So we all know about the shoulder anatomy, but I'll briefly talk about it so that we can remind each other on exactly what we are supposed to look at, and just to recap on what we already know. So the shoulder joint is a synovial joint which is formed between the scapula and the proximal portion of the humerus. It is formed by the shoulder girdle, which involves the clavicle and also the glenoid fossa. So basically, this glenoid fossa articulates with the humeral head, forming the shoulder joint. And the key major thing about the shoulder joint is that this shoulder joint composes of 4 muscles, and these muscles attach to the proximal portion of the humerus, which forms the rotator cuff. And this will be our center of discussion, where we are going to discuss this rotator cuff, which is formed by the 4 muscles, which is the supraspinatus, the subscapularis, and infraspinatus, and the teres minor. I'll try to make them so simple so that we can easily understand and relate with the shoulder girdle. From our anatomy, we understand that the tendon attaches a muscle to a bone. So I'll try to stress how these muscles, the 4 muscles that I've just mentioned, how they join these muscles to a bone, which is the proximal portion. And this rotator cuff that I want to discuss is also this structure that is so important in the shoulder ultrasound. So we'll see exactly how this will come into play and how we can appreciate them on ultrasound. The supraspinatus is located in the suprascapular fossa of the scapula and inserts on the lesser tuberosity of the proximal portion. And the infraspinatus is located posterior to the scapula, inferior to the scapular spine. It inserts on the posterior aspect of the greater tuberosity. I should mention here that if you want to understand very well the shoulder anatomy, you better divide it into 4 components, which is the anterior aspect, the superior aspect, the lateral, and the posterior. So we will have a systematic way of approaching it so that we can understand exactly what is involved. The teres minor, which is located just posterior to the scapula, it is adjacent to the infraspinatus comes and inserts on the greater tuberosity. We'll remind ourselves on these tuberosity, the medial and the lateral tuberosities, because they are very key anatomical structures in the shoulder ultrasound. The acromioclavicular joint also is a synovial joint, which is part of the shoulder girdle. This is formed by the clavicle, which is proximal, and the acromion. This is also very important in this shoulder ultrasound. They form a fibrocartilage disc that is between the clavicle and the acromion, forming acromioclavicular joint. The subacromial subdeltoid bursa also is an important anatomical structure in shoulder ultrasound. In cases of bursitis or fluid or cysts, it plays a very important role when it comes to assessment and evaluation of shoulder. But technically, this is the shoulder, the posterior view of the shoulder joint. Like I mentioned, the shoulder joint mostly is formed by the proximal portion of the humerus, which is here. Then we have the scapula, the medial portion of the scapula. Then this is the spine of the scapula posteriorly. And then superiorly, we have the clavicle.
No, not Wi-Fi. Can I put some data?
And it forms this acromioclavicular joint where it forms with the acromion and the clavicle. This joint is very important in the shoulder ultrasound because it also requires evaluation. When you look at the muscles that we are discussing about, first of all, you have to know that there are 4 muscles. We've got this muscle here, which is superior. It's superior to the spine of the scapula. This is the supraspinatus muscle. It's superior to the spine of the scapula. So it's easy to remember. This is supraspinatus muscle, the one just on top. Just below the spine of the scapula, we've got the infraspinatus muscle. This one here, it's bulky. And then just inferior to the infraspinatus, we've got the teres minor muscle, which is just down here. But they all go and join or insert at the proximal portion of the humeral head, forming the rotator cuff. So this rotator cuff that we are discussing, this is the band of tendons that joins at the proximal portion of the humeral head. Very, very important in this assessment. So you realize that it's very easy. Posteriorly, you have 3 muscles that you can appreciate: the supraspinatus, the infraspinatus, and the teres minor. The teres minor, they all insert at the medial tuberosity. Posteriorly, again, I want to also demonstrate anteriorly. Sorry, anteriorly, we have to also demonstrate how these muscles relate to the proximal portion. The most important thing to understand here is the biceps. The biceps has got 2 heads, which originates from the scapula. This is the short head of the biceps muscle, and then this is the long head of the biceps muscle. Our center of discussion will discuss more of the long head rather than the short head. So what is so important is they all originate from the scapula. And as they descend down, they come and join together, forming the belly, the biceps, anteriorly to the humerus. They form the belly of the biceps muscle. This is very, very important. Once they join, they go and insert at the proximal portion of the radial tuberosity down. This is not the discussion for today, but what is important is that their origin is from the scapula, and then they join to form the belly, which is the biceps muscle, and then they go down to insert at the tibial at radial tuberosity. But our center of discussion today is we'll look at the long head of the biceps tendon.
Just excuse me, Mr. Cuthbert. Mr. Cuthbert, just hold on. Can everybody please mute their mics? Mr. Innocent, can you please mute your mic?
Sorry.
Thank you.
Thank you so much. So you realize that the origin is all from the scapula, and then they descend down to form the belly, and then they join. The reason why I'm concentrating so much on the long head of the tendon, the long head of the tendon of the bicep, it's because it's very important to understand its anatomical structure. It causes its anatomical orientation across the bicipital groove. So it becomes key to understand on how it operates. And then anteriorly, we've got this subscapularis muscle, the only muscle which can be appreciated anteriorly. It's the subscapularis muscle, and they all join. You can see this band that is just here, which is so key. This is the band of the rotator cuff. They all come and join here to stabilize this muscle, this joint. When you look at the posterior, again, I've already mentioned, this is the teres minor, just inferior to the supraspinatus, and then just below it, you've got the infraspinatus. They all come and join in the medial tuberosity. Again, I wanted to demonstrate also the long head of the biceps. You can see it's passing through the bicipital groove, but its origin is from the scapula. So this anatomical structure is very, very important to understand and have a thorough understanding of the shoulder joint. On this image, I also wanted to demonstrate the subacromial bursa. This is very important as well to appreciate it and be aware of this bursa, because sometimes you can have abnormalities around here like bursitis or cysts may appear there. So it's very important to be aware of this anatomical structure. I'll demonstrate it on how this can be done on the sequence of ultrasound. I also want to demonstrate one of the important muscles around the shoulder joint, which is the deltoid muscle. The deltoid muscle, you may appreciate it well superiorly, and it goes down, it courses down around the humeral head, and just below it, you find the subdeltoid bursa. Just above it, you've got other structures that you may appreciate as well, but this is not the area of discussion. But one of the things that is so important that you can appreciate is the glenoid labrum. This is also important posterior, you may appreciate it. And again, you can see how the supraspinatus, again, it's coursing all the way, it's originating there, and the tendon itself, it's coming to insert. So the key lesson here on this shoulder is to realize that the whole four muscles that we have, they originate from the scapula. Four posteriorly, one anteriorly, they come and bind or join together to form the rotator cuff, which is the band of tendons. And this is the center of our discussion. So really understanding the anatomy that is involved in the shoulder joint will help us to comprehensively evaluate this shoulder ultrasound that we are discussing. Before I continue, I should also mention that shoulder joints, sometimes we tend to be scared to scan simply because maybe we may not understand, we may not orient ourselves, we may be having some knowledge gaps, or maybe even the skill or the technique on how to go about. But I can assure you that the shoulder ultrasound, if you know exactly what you are looking for, maximum you can take, it can take 15 minutes, 10 to 15 minutes, if you know exactly what you're looking at. I cannot overemphasize the issue of thorough clinical examination is very, very key. Patients who present with shoulder joint pain, they tend to have non-specific shoulder joint. However, sometimes patients may have specific pain that they may present with while they come to your department. But if you know exactly and have a systematic, logical way of assessment, it should take 15 minutes maximum. Equipment, you need a linear broadband transducer, at least 10 to 15 megahertz for an average patient. This is very important for those of us who have been practicing ultrasound. We understand the importance of the frequency. The high frequency gives you the high resolution. You compromise on penetration. Remember, we are dealing with superficial structures, so we need high resolution ultrasound. So we need a broadband of 10 to average patients may need something like 12 to 15 megahertz to increase on the penetration. For extreme patients who are so large, you may use something slightly lower, like 9 megahertz and slightly lower. Again, I should also mention here that you have to be very careful with the technique, whatever you want to perform this technique, so that you get the correct orientation that may present. I'll continue mentioning about anisotropy. Anisotropy is one of the common artifacts that you find in musculoskeletal ultrasound. This is due to failure of the ultrasound beam to hit the tendon or the muscle at right angles. You tend to have anisotropy, and this anisotropy may mislead you to think there is a tear or there is fluid or there is a cyst. So anisotropy is one of the things that is a pitfall in musculoskeletal ultrasound. Generally, the indication for musculoskeletal ultrasound, they are categorized in 4. We've got degenerative pathologies, which may include arthritis. This may include other physiological pathologies that may affect the soft tissue around the joint. This may also be due to other pathologies like synovitis. You can have diseases that may come into play, but generally you've got degenerative pathologies, the post-trauma, which may involve subluxation and dislocation, and the tears involving the soft tissue around it. It's rare that we may assess this ultrasound, shoulder ultrasound, with bone involvement, but at times, incidentally, or while you are assessing the ultrasound shoulder, you may come across some bone involvement where you find that the bones are irregular on the articular surfaces. Sometimes you may find that the acromioclavicular joint is abnormally widened due to post-trauma and things like that. Then you can have also the shoulder joint impingement, which I will discuss. You can have pathologies that may involve muscular atrophy or fat deposition. All those things, we have to be aware of them. I should also mention that before you even go to the protocol of ultrasound, ensure that you are systematic in the way you are approaching your shoulder joint. So we've got the standard examinations that we do, and they are divided into 4 components. 4 components are very important whenever you are starting your ultrasound protocol. The first, they are basically anterior, superior, anterior lateral, and posterior. For those of you who like using acronyms, I think I'll give you an acronym so that you know exactly what you're supposed to look at. And in each component, there are specific things that we look for. There are anatomical structures that we want to assess, and their related pathologies. The anterior approach has got its own maneuvers. While you are performing that particular assessment on the anterior component, there are specific maneuvers a patient must implement. You've got the superior, where you have to assess specific structures. You've got the anterior lateral component. And lastly, you've got the posterior component. I'm going to discuss them well. So what is so important is to understand that we've got 4 components. I should also mention here that protocols may differ depending on the institutions, but one clear thing that should come out is a comprehensive, systematic, logical evaluation of the shoulder joint must be achieved regardless of the protocol that you are using. the major objectives must be achieved. One, to identify the tendon of interest and its related pathologies. Image the tendon at two orthogonal planes, transverse, sagittal. Transverse, sagittal. We'll keep mentioning this. We understand the importance of these views. Eliminate the artifact of anisotropy by directing the beam perpendicular to the tendon. I'll demonstrate how you can tell that, oh, your beam is not hitting the tendon at right angles. Again, this beam that we are talking about, as you continue to scan, you rock and continue angling. You don't just approach at one point, but you keep on. You rock from one point to the other until you get the correct and the perfect image. The last objective is to diagnose the disease. Either there is normal or there is an abnormality. Protocol number one, we are going to look at the biceps brachii, the long head of the biceps tendon. Now, what is this biceps brachii? The biceps brachii, this is the structure that attaches the biceps muscle, which we all know. This biceps muscle is anteriorly located on the humerus. Now, we've got the long head of the biceps tendon, which is abbreviated as LHBT, the long head of the biceps tendon. Here we want to look at the tendon itself. We are looking at the tendon itself. Apart from that, we also want to look at the subscapularis and the biceps brachii tendon, subluxation and dislocation. This is the anterior compartment. So in the anterior compartment, we are basically looking at two things: the long head of the biceps tendon sitting in the bicipital groove. We also want to assess the subscapularis and the subscapularis tendon. Remember, the subscapularis tendon can be well appreciated in the AP because it's anteriorly located on the scapula. It's not posterior. So here, concentrate on two things: the biceps tendon, particularly the long head, and the subscapularis. Check for dislocation and subluxation. We'll discuss them. We also want to continue to look at the supraspinatus and rotator cuff interval. The subdeltoid bursa will also continue to be seen. So this is the technique. The patient is examined in erect. Preferably, the patient must be mobile on a stool, or if it's on the bed, it's fine. But the patient is erected, seated, in a seated position, with a sonographer facing the front of the patient or behind. I mentioned last time that we shouldn't be surprised when we see some protocols being done, somebody's scanning from the behind or somebody from behind, whichever you are comfortable, but I prefer myself to scan a patient while standing in front so that I'm able to see the patient and basically communicate to the patient. The protocol must be systematic and logical in approach to assess the joint. Evaluation of each component and each specific anatomical structure. I've already mentioned that patients must continue to implement specific maneuvers. While the patient is in erect sitting position, the hand is in supination, palm facing up on the lap. The transducer is placed on the axial plane anteriorly or anterior to the shoulder. This is the anterior component. So when you put your transducer on the anterior shoulder in the short axis or the axial plane, you are going to appreciate the bicipital groove with each bone characteristics around the bicipital long head of the bicipital tendon, or rather the biceps brachii. So one clear thing that you are going to identify the moment you put your probe anterior to to the proximal portion of the humerus. It's the bicipital groove, which is the depression around the head of the humeral head. Within the bicipital groove lies the long head of the BRACHII tendon in short axis. Step 1, anterior component, the area of focus is the bicipital groove. The bicipital groove where you appreciate the long head of the biceps tendon, long head biceps tendon, very, very important. Now, the long head of the biceps tendon and the subscapularis tendon, they are well visualized in this position. Supination, the palm facing up, patient relaxed, 90 degrees elbow flexion. What are the common indications for this particular structures, anatomical structures? This is where you can appreciate the subluxation and dislocation of the long head of the biceps tendon. You can appreciate whether the biceps, the long head of the biceps tendon is off the bicipital groove or it's in, or how far it is. So you can clearly see that this long head of the biceps tendon is out of its normal anatomical location. Very, very important. Secondly, you can see the rupture, whether it has ruptured or not. The rupture of the subscapularis and its involvement in the tears. So like I mentioned, the subscapularis tendon, you also see that you appreciate its insertment, and you are going to appreciate where it's inserting. So all those ruptures and involvement we are going to see. How is the orientation? I wanted to demonstrate the orientation that you are likely to see. So when you put your probe at the proximal portion, at the humeral head, this is what you are going to have. This is the bone, the schematic diagram. This is where you are going to see the bone itself. On the lateral portion of the shoulder, you're going to see the greater tuberosity and the lesser tuberosity. Why am I mentioning this? This can be confusing at times on the image. So on the right side of the screen, on the ultrasound screen, you have the lesser tuberosity. You have to be well orientated on your image. And then in the middle, you are going to have the bicipital groove. This is a groove from anatomical structures. We know what a groove is. And then sitting within the groove, just within the center, you are going to have a structure, which is the long head of the bicipital tendon. So this is the long head in cross section. On ultrasound, you see it as an echogenic structure in short axis. While in long axis, you are going to see it as a fabrial pattern. I'm going to demonstrate how it will look. Just above it or superior to it, you are going to find the deltoid muscle. So this relationship is very, very important to have in your mind, even as you scan the portion. This is the position that I was talking about, particularly the anterior compartment. You want to see the bicipital groove. So within the bicipital groove, you are going to see this image. This is the bone cortex. Sonographically, this is how the bone cortex will appear. And then we are going to have that bicipital groove, that depression that we have there. And then it continues medially this side. Within the depression, we have that echogenic structure that is there. That is how the normal long head of the bicipital tendon looks like. That is normal in short axis. It looks as an echogenic. When you see it looking more darker than the normal, it's a sign that your beam, it's not hitting the tendon at 90 degrees perpendicular to this. And this is what we call angiotropy. This is very common. This is not a cyst. This is not a tear. This is not a lesion, but this is angiotropy. Very, very important. Above it, you've got the deltoid muscle. How does a muscle looks like on ultrasound? It will have this punctuated fibril pattern that you have due to collagen structures that you see, all those things. This is a normal muscle. This is a deltoid muscle, normal deltoid muscle. Again, this is a normal structure of the long head of the biceps tendon. So you can see it's very simple. Just put there, know exactly what to look for. Don't look for other things. Specifically in the anterior compartments, check for the bicipital groove with the long head of the biceps tendon in position. Very important. This is another image that I wanted to demonstrate again. Continue to appreciate it. If you see the patient is well relaxed, seated, just put your portion there. Greater tuberosity, lesser tuberosity, the deltoid muscle. Again, we've got that echogenic structure. We've got, this is now the long axis. You can see this is now. Hello?
Hello, Cuthbert, we can hear you.
Okay.
Hello.
This is the long head. This is the long head. This is the long head of the bicep. Now, this is now, it's coming, the structure is now different. You can see those fibrostriated appearance. This is normal on ultrasound. So this is how the long head of the bicipital tendon, this is a tendon now coming here to insert on the proximal portion. Of course, you've got the deltoid muscle above there and you've got the humerus there. Again, I should also mention that external rotation in the same position, anterior compartment, external rotation, it will help you to appreciate the bicipital groove. Now, this time around, this is where you can appreciate the supraspinatus. Sorry, the subscapularis tendon now fitting. When you extend it like this, you appreciate now the groove very well, and you are able to see and assess other anatomical structures that may come in. I'll demonstrate how that may come. Again, I wanted to demonstrate this echogenic appearance. The reason why I'm emphasizing so much bicipital groove, this is one of the sources of shoulder pain. The long head of the bicipital tendon is one of the common complaint of the shoulder pain. It's originates from this area. Of course, with other secondary pathologies. Again, this is how it will appear. Okay. When you look at the bicipital groove, again, you are going to appreciate, sorry, step 2, you are going to find that, sorry, step 2, you are going to find that this, oh, sorry. Okay. So with the patient sitting in the same position, you are going now, you want to appreciate the transducer position now. This is where you see that the transducer is positioned again in the shoulder head. You want to visualize the bicipital groove. And once the bicipital groove is appreciated, you are going to appreciate now the subscapularis tendon. And this will be identified in the long axis, anterior or towards to the lesser tuberosity. So the same position anterior, remember, we are only looking at two things. You want now to see the subscapularis tendon anterior in the anterior component. So this external rotation, it's very, very important for the patient to maneuver in that way. The reason is very simple. It's going to extend or demonstrate the long axis of the subscapularis tendon, and you see it in profile. So just that extension, external rotation of the arm, it's going to give you the demonstration of the subscapularis tendon. So it starts, you can see we are in the same position, but externally rotated. So still maintain your your deltoid muscle there, where there is a D. You've got the humerus there, but you've got this echogenic structure here, which appears like a beak. Other literatures, they will describe it as like a beak. It appears like a beak. This is the subscapularis tendon inserting again on the proximal portion. So very simple, external rotation, you pick your subscapularis tendon. Anterior elbow flex at 90 degrees without external rotation, you pick the bicipital groove with the long head of the bicipital tendon sitting in the bicipital groove. The patient arm is placed, this is now where you pick in the anterior lateral compartment. Maintain your patient in the same position. The palm aspect now in this is now placed behind the back. While the patient is seated, you want to demonstrate the anterior lateral compartment. We are just in the anterior. Now this one, you want to demonstrate the anterior lateral compartment. Now in the lateral anterior compartment, the patient puts the palm behind the back with the elbow pointing posteriorly. This hyperextension is very, very important. It rotates the supraspinatus tendon out from its acromion position. So in this lateral now, anterior lateral compartment, we want to appreciate the supraspinatus tendon. Within this, now you want to come now above.
Mr. Cuthbert?
Yes.
Sorry, Mr. Cuthbert. I have to stop the meeting because there's writings on your presentation. Can you see them?
I'm just wondering who this person is. So
yeah, so just going to good evening, everybody. I'm just going to we have to log out and log in again because there's writings on this presentation. Whoever is doing it, if they can please stop. It's not something that we appreciate. We're just going to log in again so that we can continue from where we are at because I'm recording this. So it's something that we are working so hard to make sure that the presentation is perfect. So we have to all log out and then log in again.
But who is this person doing this?
Yeah.
Atupele.
Yes.
Can you hear me? What I would suggest,
yeah, I can hear you.
Okay, maybe what Cuthbert could do is just to close his presentation and stop sharing the screen, and then he does it again.
Okay, yeah, maybe try that,
So,
Cuthbert.
Yeah, but like I think the important thing is that whoever is doing that should just stop. I mean, if they want to write, they could scribble on their own board. I think we are here for business. So if we could just respect this professional engagement. So Cuthbert, maybe you could just stop sharing, and then you start to reshare again, and then see if we can lose that.
Okay.
Yeah.
You just grab host from me because I think you can only share if you're host.
Okay.
Sure.
Okay, I think I can share now. Okay, I think okay, let me just share again. Okay, I'm sharing now. Okay, can you see it?
Not yet.
Okay, maybe you can grab again the host, because I can't share. I can't share. I was trying. You are still the host.
No, Cuthbert, you still have to be the host to share. So Atupele has to give you the host.
Yeah, but she's still the host.
No, I've given it back to you.
Okay.
Yeah.
Thank you. Okay, can you see the screen?
You're starting to share now.
Okay. Okay, we can continue.
I think it hasn't loaded as yet, at least from my side. Yeah, I think you can continue.
Okay, sorry for that interruption. So the step 3, like I mentioned, we are looking at the anterior lateral, and this is where we want to appreciate the supraspinatus tendon out of its acromion position. So this hyperextension that I mentioned, where the patient's palm has to be put on the back with the elbow pointing posteriorly, our target is the supraspinatus tendon, nothing else. Now, why is it important? You are trying to pull out this supraspinatus tendon out of its acromion. So it will appear now, it will come out very nice. Now, this is where you see, I was describing it like a beak. You see it very, very well. You are still in the anterior lateral compartment. Now, to obtain a long axis of the supraspinatus, the transducer is placed in sagittal over the anterior shoulder again. Now, this is where you see it in profile. Now, when you see it in profile, this is where you can appreciate the tears and the rotator cuff again. You are going to see it. Very important in checking other pathologies like partial or full thickness. This is a very important view to appreciate when you do that maneuver. Now, again, I mentioned that this is where you can also appreciate the subacromial subdeltoid bursa. I can see Mr. Hussein, please. Okay, Mr. Hussein, you want to say something? Sorry. So our focus here, there are only two structures, the supraspinatus and the subacromial subdeltoid bursa. Very important. What are the common pathologies within here? You've got the rotator cuff tear. You've got the supraspinatus tendon, calcific tendinosis, subacromial subdeltoid bursitis. When there is fluid within the bursa, this is the only position or rather view where you can appreciate the subdeltoid bursitis, any cyst within the bursa. This is a very important view where you can see it. Like I mentioned, I'll demonstrate how the partial or full thickness of the supraspinatus tendon appears on ultrasound. Very, very important view. Take home message for these two: when you do the anterior lateral, supraspinatus tendon, subacromial deltoid bursa. When you go into the long axis view, like I mentioned, very important, appreciate the bursa, the tuberosity, and their related tears. Both partial and full thickness are well demonstrated in that. And this is the view that you need to do. A patient puts their palm on the back. You can see here the patient is still in the seated position, elbow pointing posteriorly, and you put your probe just above the humeral head. You are going to have this view. Always remember the beak of the bird. It looks like a beak. You can see this is the normal supraspinatus tendon. Very nice, well figurated. Remember, our deltoid muscle is still there, humeral head there. when there is a normal bursa, you may not see it on ultrasound, but once it's inflamed or there is fluid within the bursa, you are going to appreciate it very, very well. So this is how you appreciate it, simply by doing that. Be focused and systematic. Again, this is the same normal supraspinatus tendon. Remember, this is the tendon that is coming from the supraspinatus muscle, our four muscles located posteriorly above the the spine of the scapula. So this is above. You are able to tell that this is above. So that position is very, very important. Again, you can see I'm still trying to demonstrate the same. Very simple, but this is how it comes out. Laterally, you've got that greater tuberosity. Medially, you've got the humeral head. And then here you don't appreciate so much the lateral tuberosity because there is a bit of twisting. But again, our deltoid muscle will continue to appear just above the supraspinatus tendon. You can see it. You can see now that the deltoid muscle, again, it's nicely well demonstrated there. And then this is the supraspinatus with the biceps tendon. This is not normal. We'll discuss these pathologies. I also wanted to demonstrate this supraspinatus muscle bulky on how you can pick it. Just posteriorly above the scapular spine, you can even palpate it. You can have this normal massicular bulk. This is very normal. In cases where you have massicular atrophy, you can also see, once you know the normal, you are able to appreciate or compare if there's any fat deposition or measurements within the muscle, you can see. But this is how the supraspinatus muscle bulky appears in a normal anatomy. Step 4, you need to appreciate that you've got the posterior compartment. Sorry, the superior compartment. Now, in the superior compartment, you are just looking at one thing. Superior compartment, one thing is the acromioclavicular joint, just above the shoulder joint. How would you identify this is the acromioclavicular joint? Two bone structures are very, very important. The clavicle that is located proximal, and you've got the acromion that is more distal, adjacent to the humeral head. Very, very important. Here, our area of interest is the ACJ, which is the acromioclavicular joint. Now, laterally or towards, when you move laterally, place your probe towards the acromion, you are going to see a fibrocartilage joint. You see a disruption between the two joints. That is the acromioclavicular joint. This is done in coronal plane. Superior coronal plane, you are going to appreciate that. Identify the bone contours, very important. Evaluate the bone irregularity and the widening using the dynamic assessment. By dynamic assessment, again, this is where you can ask the patient to extend or move the arm and see the relationship. At times, you can have pathologies where there is a dislocation within the acromioclavicular joint, or there is fluid collection within the joint, or there is a cyst within there. Even masses may also appear within the joint, but the key message on the superior compartment is that your area of interest is the acromioclavicular joint, which is the most important thing. What are the major anatomical pertinent anatomy that is supposed to be looked at? You've got the acromioclavicular joint only. Common pathologies, degenerative diseases, post-traumatic injury, synovial cyst, or synovitis may present there. And these pathologies, again, you have to also be well vested on how they appear and just familiar yourself with how they may present. You can have fluid collection within the joint. You can have disruption. You can have widening of the joint itself. You may comment on those. So this is how on ultrasound you are going to appreciate it. Like I mentioned, on the proximal portion, this is the bone cortex of the clavicle, okay? This is the clavicle. Remember, there are muscles around here, so we are trying to pick the most relevant information here. So this is the clavicle. When it comes here, there is a disruption here. This is a fibrocartilage disc. This is how a cartilage will appear. And then you've got the acromion just within there. And then the humerus is around there. So within here, this is the acromioclavicular joint. This is well done posteriorly. Superior, posteriorly, you are going to pick this. Others may stand anteriorly, others may prefer to stand in front, but you pick it from this view with the patient hand abducted, relaxed position, neutral position, and you pick it. This one you don't even need to stress because there is no many maneuvers. You just have to know exactly what you are putting and what you are looking for. Again, this is the joint itself, the acromion and the clavicle. Step 5, which is the last part, you want to pick the teres minor and the infraspinatus muscle. Now, in here, again, you want to see their tendon relationship with each other in relation to the rotator cuff. The patient's palm on the lap, transducer is placed below the subscapular spine. Remember, in our anatomy, we said the infraspinatus and the teres minor, they are located posteriorly, just below the scapular spine. So you really have to know your surface anatomy and where you are putting your probe. 3 muscles, they are located behind the supraspinatus, infraspinatus, teres minor. They are posterior, but below the scapular spine, you've got 2 muscles, the infraspinatus and the teres minor. They all insert on the medial tuberosity. Very important. This is the orientation. So what is the pertinent anatomy that you are supposed to look at whenever you want to view this image? Relationship. You have to appreciate the infraspinatus tendon, also abbreviated as IST, infraspinatus tendon, the teres minor tendon, the TMT, and the rotator cuff. Again, here you are going to see that their relationship is very, very close. So what you need to pick is specific things. And this view, again, there are common pathologies that are common within that anatomical structure. One of them, there are tears of the rotator cuff, the IST, the teres minor tendon, the glenohumeral degenerative diseases. They are well appreciated in here. The palabrosis, the labrum, I think we didn't discuss it again. This is an anatomical structure that is within the intracapsular shoulder joint, where you can also find other pathologies like cysts, and the muscle bulk can also be appreciated well in this view. So the key message on this view, the posterior compartment, we are looking, the posterior compartment, we are looking at the infraspinatus, the teres minor, and the rotator cuff. How do they appear on ultrasound, or how do you position the patient? The patient still remains in a seated, erect position. You put your probe posteriorly to the proximal portion. Remember, they are all coming to insert at the head of the humerus. So this is what you get. They may appear similar, but they are not the same with the previous images. Again, this is our deltoid muscle. This is our deltoid muscle. This is our infraspinatus tendon. It's not a muscle, this one. It's a tendon now. It's coming from somewhere. Where somewhere? The posterior portion of the scapula. They are all coming to insert. That the key thing is they can only be demonstrated when the patient is in a certain position. What is the key message in terms of the compartment? The key message in terms of the compartment is that we have to know that we've got 4 compartments that we are supposed to follow whenever we are examining the shoulder joint. The anterior compartment, where you see the bicipital groove. The anterior lateral compartment, this is where you see the subscapularis tendon. We've got the superior compartment. In the superior compartment, we just want to see the acromioclavicular joint only. We've got the posterior compartment. We want to see the infraspinatus tendon, the teres minor tendon with their insertion posteriorly. And then we've got our superior compartment. Our interest is the supraspinatus. The positions, they are like that. What are the pitfalls? The pitfalls, angiotropy, I'll continue mentioning about it. Angiotropy still comes in as a major pitfall. Incomplete evaluation of the rotator cuff may also make somebody not to appreciate the structures that are involved. Misinterpretation of the normal tendons are also one of the major pitfalls in the MSK. Sometimes these structures, they may be confusing because you don't know exactly what you are looking for. You don't know exactly how a tendon will be differentiated from a muscle. You don't know how this will appear to what. But the key issue is to know your anatomy and the appearance of specific structures in relation to the ultrasound structures. The hypoechoic bands are seen when evaluating the subscapularis. This is also very, very important. When you don't externally properly rotate your arm, you are likely to find these hypoechoic appearance bands. And you may think there is an edema, there is a tear, or there's some, but you keep on rocking until you know your normal anatomy of the image. What are some of the common pathologies that we find? Oh, this itself here, this is the bursa. You pick this in the anterior compartment. Anterior compartment is going to demonstrate the pathologies within the subarachnoid subdeltoid bursa. This is where you see it nice, and you can see there is fluid here. It's just above the tendon. This is a tendon, but the area of interest is here. This is fluid within there. This is not a tear, but this is fluid. So you may not appreciate this in all the views, but the pathologies may exist. This is now a tear involving the supraspinatus tendon. Which maneuver do you pick this? You pick this within the anterior approach compartment where the patient extends their palm on the back. You are going to stretch this and you see the supraspinatus tendon. You can see there is a tear. That smoothness, that fibril, it's no longer there. So there is a tear here, you can see. And then the bone cortex is well demonstrated with the cartilage appearance there. So this was a tear. You can see arthritis here within the shoulder joint. I mentioned about degenerative pathologies. You can see there are those deposition within the shoulder joint, distorting the whole tendon and the structures involved. The bone cortex is also, it's also irregular, you can see. Then that is our muscle above there, the deltoid muscle. Again, you have this biceps tendinopathy, biceps tendon within the tendon. You've got this deposition. These are degenerative. Remember, we said it should look echogenic, sitting within the bicipital groove. This is our bicipital groove. Which compartment do you appreciate this? Anterior compartment. You get the bicipital groove. In the bicipital groove, you also appreciate the long head of the biceps tendon. So it's already, you can see what is happening here. It doesn't have that well-seated anatomical structure. We cannot overemphasize the importance of Doppler ultrasound, Doppler application in cases of suspected inflammation. You can see there is increased color flow consistent with possible inflammation. Again, these were some of the images to demonstrate some tears. There was a tear here, you can see. This is our groove. This is our bicipital groove, and you can see. And then we also have, this is the long axis, the long axis of the long head of the bicipital tendon. This is not in short axis. You can see those.
Hello, Mr. Cuthbert. Good evening, everybody. I'm wondering whether we've lost Mr. Cuthbert, but let me just wait a few minutes. Sorry, Mr. Cuthbert has just logged off. Let me just give him a few minutes just to see whether he logs on again. I'll come back to you. Okay, Mr. Cuthbert has been logged out and is having problems logging in again. Let me not prematurely end the meeting. If he really fails to log in, then I'll get back to you. Please be patient just for a bit. Oh, you're there. Okay, perfect.
Yeah, I'm there. I'm here.
Okay, that's great.
Yeah.
Okay. So should I grab host for me?
Okay, I'm just doing that.
Okay, sure.
Okay. Okay, can you see the images?
Yes, yes.
Okay, sorry for that. So this was a subluxation of the long head of the biceps tendon, and then this was a rupture of the biceps tendon. Again, you can also see the deltoid muscle. The idea is to know the structures around it. This is the deltoid muscle. This is the bicipital groove where the head of the long head of the tendon sits, and it has been pulled away from it. Then this was the biceps tendon dislocation. You can see now this one, you can see that it was well picked within the anterior compartment with the arm, the elbow pointing to behind the palm put on the back. This was the subscapularis tendon, and you can see the supraspinatus and its deformities around there. This is the bone cortex. We also have the rotator cuff. I'll discuss the rotator cuff, but here I wanted to show the tear within the rotator cuff. This is within the supraspinatus. Remember, our supraspinatus is picked within the same position where the palm is placed, on the back of the patient, and then the elbow is pointing posteriorly. You are going to extend and pull the supraspinatus within the acromion. So you will see it very well. I mentioned that this is where you can appreciate the full thickness tear. You can see from this part to this part, it has been teared. This is a full thickness. It has been teared all the way. And this is the area where you can appreciate it very well. This is a greater tuberosity. This was also a supraspinatus, full thickness tear. You can see our normal deltoid muscle. It's well demonstrated. Our bone cortex is well demonstrated there. You can see the full thickness of the rotator cuff here. Again, you can see some patients, they come with odd pathologies and odd tears. So you are able to see how the appearance may differ, but technically, this is how a supraspinatus full thickness tear will appear. That normal febrile pattern, it's gone, it's distorted. And this may, if you don't know exactly what is going here, you may think there's something else, but this is a full thickness tear in the sense that you can't see that nice echogenic striation of the supraspinatus tendon. It's gone. Then coming this side, remember you've got the biceps tendon, which is extending towards the supraspinatus. And then you've got the rotator cuff here. This is another tear that is within there, picked within the rotator cuff interval. Again, you've got that rotator cuff tear. This is also a post-traumatic tear within the supraspinatus. again, you can see the full thickness. The way you grade them, again, it's very important, but you can see that the thickness is about the breakage within the striated structures. So full thickness tear within the tendon, you won't see that continuity within the tear itself. Subacromial subdeltoid bursitis, I mentioned again that you may also appreciate it within that position where a patient is picked within the anterior compartment. Again, you come across these terms of subacromial impingement when a patient has got pain within the shoulder joint. Most of them, they are involving the supraspinatus long head. You can see the patient will just present with pain. Once you pick it, you may find there are issues within the supraspinatus tendon. Calcified deposition or tendinosis, you can see those small echogenic deposition which are foci. This is a case of calcified tendinosis. This can also be picked on, depending on the density of these deposition, you may pick some abnormalities within the X-ray that can make you go for further evaluation. Again, this was a heavy calcified tendinitis within the tendon. You could see that there was that deep calcification casting a shadow. This was a supraspinatus within there. That was still the calcific tendinopathy. This one I wanted also to show the bulkiness of the muscle itself, but you can see that the bicipital groove, when you look at the short axis here and the long axis here, when you look at this bicipital groove and this bicipital groove, they look okay, but when you look at the bulkiness within the muscle, there is that difference that is there. So sometimes patients may also come with, especially in old age, patients may present with the muscle atrophy, which you may appreciate on ultrasound. And much as you can assess them, but you also have to be aware of the related pathologies within the area of interest. I think I mentioned about muscle, the infraspinatus, normal infraspinatus, and how you may, normal supraspinatus, and how you may appreciate them. But here I wanted to show a 44-year-old man who had this appearance of the image. Here I just wanted to see how the muscle atrophy may appear. This is a normal muscle, bulky muscle. You can see even the bulkiness is okay, but once you look at the difference between here and there, you can see there is a difference even within the echogenicity. There is that lesion kind of appearance. But the key issue here is you have to look at the normal striation and any loss of normal muscle composition that is there. You can see here there is some ill-defined appearance, but still you can appreciate that there was some abnormality that was going on there. But this was classified as a muscle long-standing muscle atrophy and pain within the anterior compartment. Then we also have that partial thickness of the supraspinatus tendon tear. You can see it within the subacromial joint. That is also a partial tear within the bursa. Here, I was just trying to demonstrate acromioclavicular joint separation. You are able to see again here, you have to be aware of the normal anatomical appearance of the acromioclavicular joint, even within the X-ray. Normally, the acromion, there is a partial, just almost the normal anatomy is that the clavicle almost attaches itself to the acromion portion of the coracoid process, but this widening, again, it was confirmed on ultrasound and how it appeared. You can see this widening. the acromion is here and the clavicle is here. The distance is quite huge. I also wanted to just demonstrate or share the sample of, there are a number of reports that we may come across, but the sample of the report that I'm sharing, I'll just quickly look at the things that you're supposed to look at. So when you're reporting, sometimes we tend to write a lot of things, but you have to know exactly what you are looking at, exactly what structures do you want to communicate to the clinician, and what clinical question exactly do you want to address. And more importantly, again, patient's history is very key. Is it a post-trauma? Is it a degenerative kind of history? You look at that, you communicate with the patient. So be straight to the point. So like for this one, the first point is the right, the left subscapularis, supraspinatus, and infraspinatus tendons appear normal in fibrillar patterns. That is the catch. So when you discuss that, it should be normal. Is it distorted? Is it hypo? Is it hypoechogenic? You comment on the fibrillar patterns. In musculoskeletal, that is very, very key. That language should come out. And then mention, is there any obvious tendon tear? Is there any partial or full thickness? Is there any tendinopathy seen within the tendon? Our area of focus is the tendon. So talk about the tendons. Do you see any calcification? This is where you have to comment on them. The biceps tendon, if you saw it, does it lie within the bicipital groove? Does it appear normal? How does a normal looks like? Is it dislocated? Is there any subluxation of the bicep, the long head of the biceps tendon? From there, you go to the subacromial bursa. Is there any thickening within the bursa? Now, you can only talk about the bursa if you saw it. If you don't see it, you're not going to comment on it. So it's very important to let the patient maneuver and help you to demonstrate such things so that in your report, such things must be recorded. Is there any evidence of impingement on dynamic assessment? Again, one of the advantages of ultrasound, you find that you are able to do dynamic assessment where a patient can be told to move, relax, move while you assess. Is there any impingement? This impingement that we are talking about, is there any bone structure or any structure within the shoulder joint compressing on the other? That can be seen depending on the mechanism of injury. That can be appreciated, but the dynamic assessment is very key when you want to demonstrate the subacromial bursa so that you see, is it demonstrated? Is there fluid around the acromioclavicular joint appears normal. Of course, you have to know how the normal looks like. Is there any edematous appearance? Is there any fluid? Is there any fat deposition? You talk about it. Your conclusion can be normal shoulder ultrasound, normal left rotator cuff tendon, there is a tear, or you comment on those. But what I wanted to demonstrate on this report is that if you don't see things within your report, you are not going to appreciate them. You're not going to talk about them. So a comprehensive, systematic assessment is very key so that you come and bring them out. I've seen reports maybe where people have talked about things, but they have not demonstrated them. So I think a report is key. There are other reports, abnormality reports that I can share. But this is what I wanted to bring out for a normal. Talk about things in a systematic way. Don't write too much, because when you write too much, you are not communicating anything. So make it simple, bring out the message within there. What is the conclusion? Ultrasound is an important complementary tool for evaluation of superficial soft tissues. Generally, this is true in musculoskeletal ultrasound. We have to acknowledge that this ultrasound, being a complementary tool, MRI remains superior to it, though the sensitivity in terms of superficial assessment or evaluation of tissues, it's almost have the equal accuracy. But what is key is the ultrasound is an important complementary tool in the clinical setup. and assessment of superficial or soft tissues. Understanding the anatomy of the shoulder anatomy, it's very key, and its related diseases if you are to give a high quality diagnosis. On this point, again, it's very key. One of the challenges that we have is that if you don't appreciate the anatomy involved, you are not going to appreciate the anatomy that is involved. The technique, you have to keep on practicing so that you pick the images that are supposed to be picked. So having a solid anatomy knowledge is very key so that you are acquainted and familiar with the anatomy that is involved. A comprehensive systematic assessment is crucial. Again, I mentioned you can apply this acronym, the 4 compartments, which is the anterior, the superior, the anterior lateral, and the posterior. There are 4 compartments, and in each, you have to know exactly what you are looking for. For example, in the anterior compartment, we mentioned what to look for, related diseases. Posterior compartment, we mentioned what is supposed to be picked. One of the challenges that we have, I think you all agree with me, we have very few trained musculoskeletal sonographers to promote high quality diagnostic MSK imaging. If there are people who are performing musculoskeletal, mostly, there are few. Others, they are doing it because they have done it on job on training. It was a component in their training, and others, they've got formal training. So the take-home message for this shoulder ultrasound joint is that we have to use it as a complementary tool, identifying its limitation in relation to MRI. However, I should also mention here that ultrasound has got better advantages compared to MRI when it comes to its accessibility, low cost. You are able to compare the contralateral joint. You are able to give immediate feedback within the patient. You are able to get communicate with the patient and patient satisfaction. Unlike MRI, of course, with its superiority in terms of high detailed information, but the patient will be there, then you won't compare with this, and time consuming comes in. Understanding the anatomy, if you are to practice this shoulder ultrasound, musculoskeletal ultrasound, is very, very crucial in this position. Comprehensive systematic assessment is #1 key in this one. Anterior compartment, you are looking at 2 things, the bicipital groove and the subscapularis. The superior compartment, you are looking at the acromioclavicular joint. And then in the anterior lateral, you also want to see the subscapularis tendon. Posterior compartment, you want to see the infraspinatus and the teres minor tendon. So I really wanted to bring out this. I hope I've shown 1 or 2 things that are supposed to be seen. And then in shoulder ultrasound, always you can practice on each other so that you get to know the normal anatomy. I think that is very crucial whenever you want to practice this musculoskeletal. Thank you so much for your attention. Those were my differences. I got some images from those sources. Thank you so much for your attention. I'll give it to the moderator to take over. Thank you so much.
Okay, thank you so much, Mr. Cuthbert, for your very lovely, systematic, and very detailed presentation. If there's anyone that has got questions, if you want to raise your hands, that would be great. But if you just want to ask the question, go ahead, and then Mr. Cuthbert will help you, or anybody who's trained in MSK that is logged in can always come in and give an answer. Any questions? Contributions?
Okay, thank you. Can you hear me?
Yeah, yes, we can hear you, sir.
Yes, my name is Munkuli. Yeah. My question is on the. Okay, I actually have two questions. One is on the acromioclavicular joint wideness. Are there any nomograms that you can refer to say from such millimeters to such millimeters, or we just compare the two sides? And in the case where both sides we have some widening, how do I come to know that there is a widening? Then the second question is on the peritendinous fluid collections, and it's the same question of nomograms as well. Is there any values that we can refer to say if it's such millimeters deep is normal and above that it's abnormal? Thank you.
Thank you so much. Just to quickly respond to your question on the acromioclavicular joint, I think I also found it as a challenge. I went into my literature review. I tried to look at the nomograms. I could not see or find any. Now, what was really coming out is with experience, you have to compare the contralateral. I really never came up with the normal, unless if there's anyone with the nomograms, I would love to hear from that. But I really checked on the literature review. I didn't get anything. And then for the tendinopathy and fluid collection, I think the key message here is that you have to be familiar with the normal BASA, how it should appear. A normal BASA on any MSK, it's not visible. Even when we deal with the knee, it's not visible. But once you see it appearing, then something's wrong is happening there. So the key answer is you have to be familiar with the normal. Again, if there is anyone with normal nomograms, I still have to learn. But what is also coming out in the literature review, be familiar with the normal variants, the normal anatomy, and its appearance on ultrasound, taking into consideration the techniques. Remember, angiotropy may also mimic some tears and fluid collection. And then consider also the clinical history of the patient. Thank you. Unless there is anyone, they can add on those. I hope I've tried to respond to your query.
Yes, thank you. Thank you very much. We'll answer.
Thank you, sir. Any contributions? People, you may have come up with some nomograms, you can always share. Hello, the house is too quiet. Are we safe?
Yeah. Any questions, contributions?
Hello, Mr. Cuthbert.
Yes, sir.
Thanks so much for the presentation. Very informative.
You are welcome, sir.
So in trauma, the patient may not be able to sit. Can this to be done with the patient supine?
Sorry?
I'm saying in trauma, most patients
Yes.
may not be able to sit. Can the exams to be done in supine position?
Again, I'll respond this in relation to how I presented it. Remember, a patient must constantly be making or implement some maneuvers. So for example, if I want to appreciate the supraspinatus, it will be very difficult for me to tell the patient to demonstrate, because specific maneuvers will bring out specific structures. So you may find it a challenge unless there are some obvious things that can be picked, but minute or subtle abnormalities may not be picked when you just do a patient in a modified way. However, it's very important to have, when you have experience in what you are doing, and you know exactly what you are looking for, in my opinion, I think that can still be done, provided you know exactly what you are looking for. But just superimposition, and you want to demonstrate certain specific structures, you may not bring them out. Like, how do you see the bursa when the patient is in stone? Unless if it's obviously inflamed.
All right. Thanks so much.
Thank you so much, sir.
Hello, can you hear me?
Yeah, we can hear you, sir.
Yes, my name is Fuel from Zimbabwe.
Yes,
I would like to thank you so much with your presentation. It was a well-detailed presentation. My question is that what are the sonographic difference between acute and chronic impingement, for example, for the rotator cuff muscle?
the difference between?
The sonographic difference between acute and chronic impingement, that is for the rotator cuff.
Okay. Sonographically, when you have a chronic condition happening within the soft tissue, if it's a chronic, first thing that should come into your mind, what is happening within that soft tissue? All chronic conditions, they present with increased echogenicity, with gradual deposition of dystrophic calcification. So for chronic cases, check for deposition of fat deposition, or deposition of calcified deposition. And then for acute, you look for hypoechoic, or it will appear edematous. So it may appear to be more hypo. Now that is a sign of edematous. There is an inflammation, and then color will also help you. Where there is an acute inflammation, there will be increased flow on color Doppler. So sonographically, look for two echogenicities, hypo or hyper. In chronic, you expect that hyperechogenic, and why, we must explain where that is coming from. Chronic, remember the sequelae of chronic inflammation is dystrophic calcification is one of the key features. So that will come out like that.
Okay, thank you.
Mr. Daly, so you have your hand up. Would you like to ask a question or make a contribution?
Okay, hello, good evening, everyone. Thank you so much, Mr. Cuthbert, for the presentation. Yeah, we're learning a lot. And thank you for the platform. Yeah, so my question is on the patients that have got recurrent shoulder dislocation. So what are the key features and what exactly are we supposed to look for? Yeah, what's the pathology related to recurrent shoulder dislocation? Thank you.
Okay, shoulder dislocation. I think here we categorically we want to appreciate the soft tissue, particularly the extra capsular joint structures. So for me, if there is already a non-clinical patient with that, and it cannot be appreciated on an X-ray, I'll do the soft tissue ultrasound. And one thing that I'm going to pick, depending on, remember, these patients, they are coming with a clinical question. So a clinician who is sending that patient must do a thorough assessment. So my job as a sonographer, I'm going to look at what are the appearance. I may not see the actual dislocation or recurrent dislocation, but I'll look at what is the mechanism. For example, mechanism of the subscapularis tendon. One of them is that it's to stabilize the shoulder joint. So I'll quickly go into subscapularis tendon. I'll look at it. Is it okay? Is it fine? And I'll do mostly the dynamic assessment, because where you have dislocation, you expect some loose joint connection within the soft tissue. So in my opinion, again, I'll still look at the soft tissue. And if the soft tissue cannot give me any information regarding to the dislocation, I would definitely advise the patient to go for other modalities which may exclude. But for ultrasound, really, I may not